Okay.
Thanks.
So let's, may listen to the same things several times, but this is good because we need some overlap. So you see the same concepts from different people and you understand those better. So, scarring alopecia, what to look for. I'm going to discuss 4 topics. Inflammatory scalp disorder, how you select the optimal site for your biopsy. This is crucial because if you take a wrong biopsy, you get a wrong diagnosis. And how you can use dermoscopy to follow up and response to treatment. So, we already heard scarring alopecia, you have loss of follicular openings. And this may be or may not be associated with inflammatory changes. And presence of inflammatory changes indicate that the disease is active. So, of course, for you that are interested in transplantation, if you want to transplant scarring alopecia, you have to be sure there are not inflammatory changes, because if they are there, that is not going to last. And the black scalp, you already heard, there is a difficulty in assessing loss of follicular openings. Why? Because the black scalp has these pinpoint white dots, you see those there, that you see in a normal scalp, you see in scarring alopecia, and you see in non-scarring alopecia. Why they have these pinpoint white dots? Because these dots correspond to both follicular openings and sweat gland openings. So you have in the normal scalp, you have a few pinpoint white dots because these are the sweat gland openings that are normally in the scalp. And then you have in non-scarring and scarring alopecia because they also have the follicles and again the sweat glands. So it's more difficult to make this diagnosis. This is the original paper from Brazil. They took a very small biopsy and they show that the pinpoint white dots corresponded also to sweat gland openings. And then how can you then assess scarring? So you have to look if the dots are regularly or not, or irregularly distributed. So if they are regularly distributed, it is non-scarring. Here you see they are irregular, and you have the white patches that Alessandra also showed you, so this is scarring, okay? So you have to look at the distribution and you have to look for patches. So the most important diseases you can see with dermoscopy, the most common are of course lichen planopilaris, frontal fibrosing alopecia, and discoid lupus. In lichen planopilaris, this is the patient that I wanted to diagnose. So somebody coming just with scalp itching without very big patches, because here is where you can make the difference. And here you see loss of follicular openings, and you see the inflammatory changes, which are these peripilar casts. Another very important feature of lichen planopilaris is hair tufting, meaning that you have 2 or 3 shafts coming together surrounded by a peripilar cast. So let's see the definition of this peripilar cast. These peripilar casts, by definition, are white, concentric scale that surround the hair shaft at its emergency. Thickness is variable, and we have a paper that is going to be published soon showing that thickness is related with the lymphocytic infiltrate at pathology. So the thicker they are, the more lymphocytes you have. And they are a sign of disease activity. So I already said, you always use dry dermoscopy to look for the casts, otherwise they disappear with the interface solution. And here you see very well the tufting. You see, you have 2 hair that emerge together surrounded by a cast. This is very, very suspicious for lichen planopilaris. And you see the pili torti that already Alessandra showed you, and they are very, very common. When you see pili torti, you have to think of possible scarring alopecia. And the frontal fibrosing alopecia, another very typical case. Keep in mind that these patients usually come for hair loss. They don't come and tell you, I'm a receding hairline. They come saying, I'm losing hair. So you have to look for that. And pay attention to the papules that are very typical. And so you will miss the diagnosis if you don't look at the hairlines. And you have to look at the hairlines and look for vellus hair and the peripilar casts. And here is another typical example. You have the peripilar cast and you have no vellus hair. In frontal fibrosing, the peripilar cast may be very subtle. It's not as in LPP. So that's why the absence of vellus hair is important. And then you have the other features that Alessandra showed you, the broken hair, the scalp erythema. You can have black dots. Here you see a few black dots. It's not like in alopecia areata you have many. In frontal fibrosing alopecia you may see 1, 2. And you see the same features in the eyebrows. You see the peripilar casts. And you even see in the body hair, because these patients also lose hair in the arms and in the legs. And if you look with your dermatoscope, you can see casts surrounding the few remaining hair. Let's now look at inflammatory scalp disorder. So the most important thing in inflammatory scalp disorder is look at the vessels, because the vessels can help in making the diagnosis. So in seborrheic dermatitis and contact dermatitis, you just see an increased number of arborizing vessels. In scalp psoriasis, you see the twisted capillary loops. And then in connective tissue disorder, you have enlarged tortuous capillaries. I'm going to show you some example of that. And I have to say that recently I see most patients with hair loss, they also have inflammatory scalp disorders. I have the feeling that is a kind of something that is increasing, and of course may change the results of treatments. So here you see the arborizing vessels. Okay, these are also seen in the normal scalp, because the arborizing vessels are the deep plexus, but in inflammatory scalp disorders, you see an increased number of these arborizing vessels. So we don't have a way to distinguish seborrheic dermatitis from contact dermatitis from dermoscopy. But psoriasis has a different vascular pattern. So here you see scalp psoriasis at low magnification, and you see these red dots. And if you go up at higher magnification, you see the twisted capillary loops. These are very, very typical, and so dermoscopy can give you a presumptive diagnosis of scalp psoriasis. And then we have connective tissue disorders. And you see the vessels of the scalp are very similar to the vessels that you can see in the proximal nail fold. And these are pretty diagnostic. So sometimes, for instance, dermatomyositis can present just with hair loss and itching. And you look at the scalp, you see these vessels, and you can make the diagnosis. So vessels are very important to look for. Here, for instance, you have a scalp which is very inflamed, and you see some peripilar casts, so you can think this is lichen planopilaris. But you don't see these vessels in lichen planopilaris. So when you have these vessels, you have to think of discoid lupus. And discoid lupus may cause peripilar casts like in LPP, but you have the vessels that make the differential diagnosis. So another very important point has to select the optimal biopsy site. And I published this paper on dermoscopy guided biopsies many years ago. Not many, maybe a few years ago, let's say. So use the dermatoscope to select the biopsy site. Because, of course, in this way, you see a feature and that will allow the pathologist to look at the area that is the most affected, okay? Otherwise, you may just take, for instance, the scar, and the scar will not give you information. And especially in case of hair transplantation, you really want to assess inflammation, so you really need to do that properly. So the area to select depends on disease, and here is a list of features that you have to look for depending on disease. So in lichen planopilaris, frontal fibrosing alopecia, and lupus, when you have the peripilar cast, this is the right place to biopsy. So try to pick up an area with peripilar casts. In folliculitis decalvans, for instance, you have to pick up an area with a tufting, so 6 or more hair emerging together surrounded by white scales. In central centrifugal alopecia, you have to pick up this hair with the white-gray halo. And in discoid lupus, you may have different areas, either where you have follicular plaques on follicular red dots are good area to take the biopsy. So it's very important. Here you see, for instance, a case of frontal fibrosing alopecia. I pick up this area with the peripilar cast. I'm pretty sure I'm going to find the features there. And always ask the pathologist to do horizontal sections, because of course, here you have 2 hair. If they do vertical sections, your hair won't show in the biopsy. And follow up during treatment. Look with dermoscopy, you can see here the peripilar casts are not there anymore, meaning that the treatment is effective. And the same in this case. So it's very useful for that. And this is, again, thank you very much.